evening, everyone. It is a pleasure to open the next in our series of keynote talks on Zoom, which are available also on your YouTube channel as part of the Hamlyn Symposium 2021. Today, we are absolutely delighted to have Ann Majewicz Fey from Texas, University of Texas, Austin, for her keynote talk. So Ann is an associate professor at the University of Texas in Austin, where she directs the Human-Enabled Robotic Technology Lab. On completion of her double bachelor in mechanical engineering and electrical engineering at the University of St. Thomas, and her master's in mechanical engineering at Hopkins, and her PhD in mechanical engineering at Stanford with Alison Okamura, she joined UT Austin in August 2020. Her research interests focus on the interface between humans and robotic systems, with an emphasis on improving the delivery of surgical and interventional care, both for patients and healthcare providers. Her talk is entitled From Tool to Assistant, Developing Adaptive Surgical Robots for the Operating Room, and I'm absolutely delighted to give her the stage now. Ann, thank you. Take it away.
Thank you so much for that kind introduction. And it's such a pleasure to be here and to be able to participate at Hamlyn. I think I went to the very first Hamlyn Symposium, but haven't been able to go since then for many reasons. So it's really a pleasure to be able to attend, even though it's virtual. So thank you for that kind introduction. So first, I'll just tell you a little bit about me, where I am now. And I used to actually be at the University of Texas at Dallas, but we recently moved to UT Austin. My lab is the HERO Lab, Human-Enabled Robotic Technology Lab. And our goal is to improve healthcare by translating effective robotic technology into clinical use. So at UT Austin, one kind of exciting thing is they renovated a historic gym that used to be a gym for women into a state-of-the-art robotics research facility. So that's been kind of an exciting thing that we've had here at UT Austin. Just to give a quick shout out of other faculty that are at UT Austin, in case there's any students that are on this call, maybe thinking about where you might want to land for a long-term faculty job. There's a lot of great researchers at UT, and we're growing rapidly, our Texas robotics group. So I certainly encourage you, if you're interested in exploring Texas, to think about us and reach out if you have any questions. So jumping into the talk, first let's define surgical robotics a little bit. Definition of a robot is a machine that is capable of carrying out complex series of actions automatically, either especially programmed by a computer. You're all roboticists, so I'm sure we don't need to have this definition. But when we look at surgical robotics today, we see that they actually fall quite short of this true definition of a robotic system. And certainly there's been a lot of work recently to, bring more intelligence and autonomy into robotic systems, but where they are now is still essentially not to demean anything, but sort of a fancy joystick. And there's lots of challenges in surgical robotics, and several of the leaders in surgical robotics have recognized this fact of the limitations of robotic systems and sort of outlined various levels of autonomy that you could potentially have for surgical robotics, ranging from our current state for many of the surgical robotic systems where there's no autonomy to fully autonomous systems. And there are some, there are some robots on both ends of the spectrum, but there's sort of a missed opportunity to really look at the middle where you have humans integrated in the control loop. So you might think, well, we could just automate robotic systems, oops, sorry, why shouldn't we do that? Sorry about that. And I think there's certainly a lot of really exciting technical challenges with trying to do fully autonomous surgery, but the reality is that real surgical environments are extremely complex, they're very dynamic, and it's really important that we have ways to integrate human knowledge, intuition, and instinct to ensure that our overall robotic systems are safe and effective. So the long-term goal for my lab is to really start thinking about the next level of human adaptive surgical robotic systems. So not just having so having robotic systems where we can actually study the way in which the human interacts with the robot to understand things like operator intent, innate expertise levels of the surgeon, the difficulty of the intended task, also thinking about potentially adverse events that we can detect on the patient side, and using all of this information to really drive the control action decisions that are going to help us change how we control the robotic system. So that's sort of our long-term goal. But for this talk specifically, there's sort of 3 points that I want to talk about. One I'm going to touch on is the impact of the robot presence on the human operator, understanding bimanual coordination, so how your two hands are coordinated in surgery, and then sort of a little bit of an idea, I guess, on robot-free surgical robotics. So let me start with the first one. And before I get too deep into what this study was, I wanted to give you a little bit of history, why we thought this was an important question. So at UT Southwestern, which is the surgical, the medical center that I work closely with, they have an established robotics curriculum that consists of 9 different tasks that they use for the Da Vinci robot when they're training robotic skills. So there's some typical ones like peg transfer, suturing, running suture, pattern cutting, and different things related to the camera placement and clutching. So this is sort of an established curriculum that's been well studied and validated and used across all the robotic specialties from urology, OBGYN, and also general surgery. And we wanted to explore what's the impact of doing virtual reality pre-training on the ability to teach these validated robotics skills. So we selected we tried to match virtual reality tasks to all of these established dry lab tasks using the virtual reality system. So this came from the Da Vinci backpack. This was the SI version, so before the XI, and I know they've changed all the VR tasks, so this was before that change. And so we matched sort of tasks that were similar to the goals of the virtual reality, the inanimate exercises. And we wanted to see what's the impact of this virtual reality pre-training on then a transfer to skills on the real robotic system. And so this is just some preliminary, an initial data set. We don't have the full data set fully analyzed yet, but we had 9 residents per each group. The residents had 1 month of training time on the VR before they all then tested and trained on the robot. They also did an initial pre-test on the robotic system before the virtual reality. So overall, as you can see in this plot here, the virtual reality training was statistically significant in terms of reducing the number of repetitions you needed to achieve task proficiency. And that's something that's fairly well known and well studied, that overall virtual reality seems to have some benefits. But if you look a little closer at some of the very specific tasks, task 4 and task 8, were simple suture and pattern cutting. And what was really fascinating to me about this study was that the subjects who did virtual reality pre-training actually had worse performance in those specific tasks than only the robotic trained individuals. And what's more fascinating to me is those differences, those decreases in performance actually persisted after the full robotics training. So it was like there was something that they were learning in the VR task that had lasting negative, in this case, impact on their performance. So this was just a little pilot study that got us really interested in having a better understanding of what's the role of the robot when you're actually doing surgical tasks. So in order to understand this a little bit better, we did an experiment where we recruited a understandably small number of subjects, so 4 across different expertise levels, and we randomized them to do virtual reality and real robotic tasks. So you can see them here taking place. There was a tubes task where you had to pass a needle through some tubes, and then a continuous suturing task. So they were randomized into either doing virtual reality first or the real physical tasks first. And they did each of the tasks 3 times. So overall, we had 18 trials per subject. 72 trials overall. And to give you a sense of, why there's only 4 subjects, each of these experiments, we also collected video data, we collected muscle activity, inertial measurement units, so their accelerations and velocities, skin conductivity, all sorts of measurements off the human user, as well as position tracking. And the data set was, quite large and sort of prohibitive to really bring more subjects into the group. But we wanted to try to understand what's the role of this robotic system nonetheless. So in terms of our results, some things that were really interesting was that if you look at the kinematic metrics, subjects that were training in the data from the virtual reality simulator versus the actual robotic system had a significantly higher economy of volume than the robotic system. And the path length for the robotic system was significantly higher than the virtual reality system. And then also the robotic task had significantly higher muscle activation. Skin galvanic response, which is your measure of skin sweat and anxiety, was slightly higher for the robotic system, but that wasn't a significant factor, most specifically for just the pick and place task, which is the simplest task. But anyway, so this was the first kind of human-centric look at the role of the impact of the robotic presence on a human operator when they're doing tasks. And for us, it really gave us an interesting, it gave us, it helped us sort of think about the importance of the human side of robot-assisted surgery and, the impact of designing virtual reality systems that maybe don't necessarily reflect the true robotic experience, and how that may have lasting impacts on long-term training. Okay, so let me switch gears a little bit to a different project. So kind of in this vein of trying to more fully understand the human operator with a robotic system, this is work that my PhD student Jacob has been working on. And here what we're trying to study is to really understand what bimanual coordination means in robotic surgery. And bimanual dexterity is a common element of surgical assessment. So in the gears domain, bimanual dexterity, an expert is supposed to use both hands in a complementary way, whereas a novice will use only one hand, they'll ignore their non-dominant hand, and they have poor coordination. And that's something that you can clearly see from these two videos is that, when the expert moves, the two hands are very well coordinated together, they're synced together, they sort of flow naturally between the different tasks. But what we didn't know was how do we really quantify what this means to be well coordinated? And what does, how do you know that you're being complementary when you're actually controlling a bimanual robotic system? And there really wasn't much in the literature to try to understand this bimanual coordination. We have seen in prior work, there's been a lot of effort to try to decompose movements in more automated ways. So for example, using gestures or surgeons, that's work coming up from Johns Hopkins, where you sort of decompose surgical tasks into subtasks like reaching, transferring for a needle. People have also looked at kinematic synergies, which is a way to try to identify sort of like a basis set of the most critical or the most key ways that somebody can coordinate the way that they move or the way that they hold their hand. And what we sort of thought about instead is neither of these really get at what we're trying to understand, which is how do the two hands coordinate. So we started instead just thinking about, okay, well, what are all the possible options that I can control the two of my hands together? So, you could have a single target task where your hands move together to move together towards the target. You could have your hands moving in a symmetric fashion towards one target or sort of in an asymmetric fashion moving towards that single target. You can also have two target tasks where your hands sort of move to two separate targets. And there also your hands could either move in a symmetric fashion. You can have different types of symmetry. So mirrored symmetric, point symmetric is sort of a rotation about an axis. You can have sort of visual symmetric where your hands are kind of moving together as if they're fixed with a rigid link. And you can also play with things like scaling. So one hand moving more than the other, and sequence, where one hand might start moving and stop, and then the other hand starts and stops. So you might wonder, like, why are we really interested in this for surgical robotics? And it really comes down to, if we're trying to find ways to assist the user in doing surgical tasks, if we don't know what the two hands are doing, the kind of feedback that we're going to provide to them will look very different depending on if the movements are, symmetric in one target versus two targets and not symmetric. So that was really the motivation, to try to better understand how someone coordinates their two hands. So in order to figure this out, we decided to do a human subject study where we used two haptic devices, and on the computer screen, we pre-programmed some leader cursors that were sort of just little balls on the screen that were traveling in a randomly ordered path. And both of your hands had to follow this trajectory. And we went through the whole set of possible trajectories, either symmetric, changing sequence, changing the number of targets, and so on. And so as the user was doing this task, we collected the position data from the haptic devices. We also looked at the inertial measurements of the limbs. So we had acceleration and rotational velocities that we collected from the forearm and the upper arm. And then we basically just analyzed the data and to study it. So we have sort of a lot of plots in the paper that you can kind of go and look at later. These are published in JMMR and Transactions on Human Machine Systems, but I just wanted to summarize some of the key, really interesting findings. So first, we sort of understandably so, we saw that two target tasks were objectively harder for subjects to reach. And some of the objective metrics we looked at were time, path error, things like that. So two target tasks were harder. When we looked at the jerk of the movement, that actually correlated to better performance in the task, which was sort of interesting, because the role of jerk when it comes to analyzing human robot interaction, I think the jury is still out on, is higher better or is lower better? It kind of depends on what you're doing, I think, is the answer. Scaling movements negatively impacts your opposing hand. And one really interesting one was that when you're doing simultaneous bimanual movements, your non-dominant hand actually performs worse, but it's not true for the dominant hand. So those kind of give us some interesting guidelines if we're going to start thinking about providing feedback to the user online as they're doing bimanual surgical tasks. These are things that you might want to keep in mind to help decide what kind of feedback to give to the user. But of course, in order to do that, we need to be able to classify and understand these movements in an online fashion, or as close to real time as possible, in order to realize this goal of providing online robotic assistance. So what Jacob has been doing is working on a mathematical framework to characterize these types of motions in terms of their direction and their symmetry. And I won't go into sort of the mathematical details for what he's developed, since it's an article that we still have yet to submit, but I will show you some of the preliminary results. So we sort of have a kind of a mathematical framework for classifying these different kinematic features that we then use to be able to predict things like direction and symmetry. And here's just a video showing the user doing our data collection tasks. And overall, we've been able to do pretty good in terms of classifying direction and symmetry. There are some issues with some of the symmetric movements being misclassified that we're still kind of trying to work through. But it's sort of our first little step to better understanding the role of the two hands in robotic tasks. And to sort of bring back the relevance to robotics, let me just sort of skip ahead a little bit here. Here's just some videos that show the online classification of different gesture classifications. So one being making a C loop, so looping the suture versus pulling the suture apart. And this algorithm is designed to sort of work in an online fashion. So as you're collecting kinematic data, you classify the type of movement. Okay, so the last little topic I wanted to touch on was sort of this idea of, doing surgical robotics. Do you really need the robotic system? And one of the most probably ubiquitous medical tasks is needle insertion. And just a quick look of, and I could have gone to the literature, but I just sort of went to Google Images and I was surprised how many different robotic systems I found. But there's been lots of robots that have been developed over the years to do something even as simple as needle insertion. There have been devices for radiofrequency ablation, for brachytherapy, needle steering, and sort of bio-inspired work. There's some great stuff from Imperial related to that, and there's really a lot of robotic systems. But if you think about just what a simple needle insertion task is, what do you need to be able to do a needle insertion? Well, you need to be able to position the needle. So that's 3 degrees of freedom for positioning. Once you're at your insertion site, you may need to orient the needle so that you can align it with your desired trajectory. And then of course there's an insertion. So once you have the needle lined up, then you can place it. So it's not necessarily that complex of things that you need to do. And for this study, we really just focused on common 2D movements. So if you were moving in 2D, you would move your needle up and down, left and right, and then you might need to pivot the needle to rotate and insert at different angles. So we sort of say that's your diagonal insertion to the left or to the right. So we could develop a robotic system to do this, but the human arm is actually a sufficient mechanism to do that. So why don't we just use the human arm, but instead find a better way to tell it how to move? So that was really the idea behind this study. So the question here, though, is, well, what does it mean to be intuitive when you're trying to guide someone's movements? If you look at like the motor control literature, people will talk about how movements are encoded in joint space. So you could think about providing feedback to the user that defines how they should, rotate or control their elbow joint. But there's other mappings too. So for example, Cartesian control, you could also think about this thing called tool space control. Let me explain those in a little bit more detail. So joint space control, the idea here is I'm trying to guide the user on how to control the joints of their own arm limb, so their robotic mechanism. So what we evaluated were using vibration cues that were positioned on opposing sides of your wrist joint. And so when those turned on, then it sort of gave you the sensation of needing to flex that particular limb joint. For rotation, we had a series of vibration motors on the back of the arm that you would turn on in sequence. And so that ended up feeling like a stroke and was actually pretty compelling to cause you to rotate your wrist. Our tool space control cues are maybe the ones that are a little different to think about. So the rotation is the same. Here, the idea is providing a vibration cue that tells you how to manipulate the tool that's already in your hand. So you're either going to insert the tool that's already in your hand, or you're going to orient the tool that's already in your hand. So we had a rotation cue for orientation, and then for insertion, it was just a vibration cue on the back of the hand or on the inside of the palm to move up or down. And you can combine both of these together, the rotation with the up down, to be able to get the diagonal movements. And then the third one is sort of this Cartesian space control, which at the time when we started this, I was sort of interested in because I was doing needle steering teleoperation. And we saw that Cartesian control for these highly steerable needles was the most effective for human users. But I didn't know what it would be for something simpler, like just a needle that you're holding in your hand. So the idea here is you have a crosshair of vibration motors on the back of your arm, and you can provide strokes either up or down to indicate forward and back movement. You can also apply just single vibration cues on the sides of the forearm to have the user move left or right. And then since you have this kind of crosshairs on the back of the arm, you can sort of do a diagonal sweep where you turn on these motors in sequence and sort of sweep them this way or this way to be able to create a diagonal sensation across the arm. So it's not a really sophisticated system. I'll show you the picture here. You might laugh at me because of all the wires. It was actually, we had 2 high school students that were working in the lab the summer that we did this. And so they put it together. I think, for high school students, they did a phenomenal job. So, so I'm pretty proud of it, even though it doesn't look like much. But so we've got these vibration motors on the hand here, and here's a user that's interacting with our experimental system, again, using a haptic device, where we had users move in very predefined directions, and those were up, down, left, right, and then at the two diagonals. So it was just a 2D experiment for this study. We also constrained the user using a haptic wall. So we sort of constrained the insertion plane. And as they did the task, we recorded movement from the haptic device. They did a training experiment where we provided visual cues along with the vibration cues in a pre-training. And then for the actual experiment and the data that I'm going to show you next, that was all without any visual feedback. So after training. So in terms of some of the results, first, this is an example movement from one of the subjects, and just to show that the subjects were able to move in all directions for all the cues. And overlaid on one of these is all of the data. So all the data from the joint space cues, the Cartesian space cues, and the tool space cues. And I forgot to mention that we had, I think, I don't remember now how many subjects, but it was, they either had one or the other cue. They didn't have all the cues. We had them sort of separated into groups in a randomized fashion. So, no, I'm sorry, I made a mistake. They got all the cues in a randomized fashion. Everybody got all the cues in a randomized fashion. And there was 12 subjects, I think. So in order to assess performance of doing these insertion tasks, we computed a sort of a normalized error, which was a unit vector, the difference between the unit vector of the desired movement direction, so what we asked them to do, versus what the user, how the user actually moved, and we fit that to their, initial movement trajectory. So what was really interesting here, first, a straightforward result is that the up-down movements overall had, the up-down movements for tool space control had significantly less error than either the Cartesian or the joint space cues. And in terms of I'm sorry, I didn't label these very well. Okay, sorry, this is the diagonal. So this is the up-down movement, and these are the diagonal movements. For the diagonal movements, the Cartesian space had significantly greater error than the two diagonal movements, and the left diagonals had slightly more error than right diagonals. And one thing that I find really interesting about this study is if you kind of go back and look at what is the difference between these coordination modes. The up-down movement for joint control is pretty much the same as tool control. There's a vibration motor that's on the back of the hand, but it's sort of this addition of the one on the elbow that maybe gets people a little confused. So it was interesting to me that these were so different, even though the cue was actually kind of similar. Overall, subjects also thought that the tool space cues were less difficult than the joint space cues, and the diagonal cues were the most challenging, especially ones that kind of went across the body. So anyway, so our next step with this is extending the robotic sleeve to 3D, which we've sort of already done. We were about to start doing human subject studies right before the pandemic hit, so we're finally kind of able to collect data from subjects again. And so our extended version of the glove also includes a sort of a pitching motion with the tool so that you can do 3D movement. And yeah, so some of our preliminary results have been sort of mixed. People do really well with the training trials, but the preliminary testing trials were sort of all over the place. And we kind of optimized our algorithm, and I'm hoping that we'll get some, better results by the end of the summer. So that sort of brings me to sort of all the topics that I wanted to talk about. So I'll leave you with just a few final thoughts based on what we've kind of learned by doing all this. So first, we talked about the impact of robotic presence. And my kind of takeaway here is that humans are incredibly complex. And I think that by understanding them better, we'll be able to create more adaptive and collaborative surgical robotic systems. And yes, you could fully eliminate the human, but I'm not sure. Yeah. And for some people there's a lot of fun in that. But for me, I'm really fascinated about the human part of it. Especially because there's, a lot of technologies that we could leverage more to try to better understand what the human user does. So this is just a little graphic that I put together about different types of, skill assessment, metrics that are potentially out there. And if you want to include human sensing in the control loop, you really sort of have to look at things that are fast enough to enable that. So, potentially muscle activity, position movements, if you're lucky enough to get the robot encoder readings. But there's sort of some other things that we can kind of look at too, that we could potentially integrate with automated control systems, or at least semi-automated control systems for the robotic system. The next thing we talked about was the bimanual coordination. And here I think, even though there was no robotic system as part of that loop, part of that work yet, these sort of fundamental human robot interaction studies, I think, are still a necessary starting point for, the long-term goal of more adaptive robotic systems. And then sort of this final idea, why use a robot if a human will do? The more I learn about how humans learn complex medical skills and how, surgical skills are trained, the more interesting it is to me to think about other types of technology that can assist the user in doing different tasks that maybe don't look like a traditional robotic system, but they still have, a lot of the data-driven aspect of it, and there's still hardware involved. There just might not be an actual mechanism. All right, so that was the end of my talk. Thank you all for listening. Just a quick acknowledgement to some of the great students that have worked in my lab. Thank you for listening. And if there's time, I'd be happy to take any questions.
Wonderful. Thank you very much, Anne. That was a great talk. Okay, we have a few questions from the audience. I have a few burning questions myself. So let's start with Guido, who says, "Dear Professor, thank you for the great talk. My question refers to the VR versus real robot topic." I should actually click this button. "Roughly at the same time you were running your human-centric study, I was at Hopkins in Professor Brown's lab, and we ran a very similar experiment where they tested subjects on two identical needle-driving exercises, one in VR and one as an inanimate, yes, indeed, inanimate sensorized dry lab task. We found out something that aligns well with your findings. Subjects trained in VR did not fully transfer the learned skills to real robot operation. Literature from other contexts kind of agrees too. So the question is, what in your opinion might be the main factors that are lacking in current VR simulators from the motor learning perspective?"
Yeah. That's a fantastic question. And first, thank you for validating my research. Yeah, so I think that's kind of a loaded question. I think things that we know for sure are not good yet in virtual reality simulation is suturing. So, being able to more fully model and understand how the suture thread works. And also the tissue, there's, it's interesting because, this experiment that we did, it was simple tasks, right? And even your needle insertion is simple tasks. I think for more advanced VR, there could always be improvements to the fidelity of the simulation. I think we also don't really know, where is the fidelity needed? And that's sort of why we're so focused on studying the human as part of the surgical robotics loop, because the more that I can study and understand how experts do really nice knot ties, and I can sort of see the signatures, I guess, of, that mastery, then maybe I don't need a VR simulator. Maybe I just need to train them on doing the right kind of movement over and over again. And I think we just don't know enough about how humans learn these complex skills. And so if you're asking for, quick things that I think people could work on, tissue cutting and suturing, I think are big. And then beyond that, I just think it's going to require a lot more study of humans interacting with these things and using different kind of data, different kind of sensing technologies and data-driven methods to really try to understand what's happening. But yeah.
Thank you, Ann. We also have a question for Karthik, and he says, how far are we, in your opinion, from having a fully autonomous robotic system? And I guess I should add, and should we even attempt to go for full autonomy given what?
Yeah. No, there's been some phenomenal work that has not come from my lab, but has come from other labs. And I think those are important things to keep working on. Like, I don't mean to discount any of the fantastic work in autonomous surgery, because it addresses a lot of really important things, especially trying to understand what's happening in the patient environment. I think there's really some great opportunities for using computer vision and other, advanced learning techniques to better understand what's happening on the patient side, and the human side too. So, how close are we? Like, well, there is some automated surgery that's kind of happening there, not real automated surgery, but we can certainly have robotic systems do parts of surgery autonomously. And so it's sort of there, would we ever be fully autonomous? I don't know, but I think, by better understanding the human, I think we might find some really exciting questions that help us create even more effective, useful, and accepted, I guess, technology that the surgeons would be excited about.
I have a standing bet with one of my probably my very first PhD student, in fact, as to when this would actually happen. And I remember that 15, 16 years ago, I thought never. And of course, now I have to sort of eat my words, because progress on every level, including on the software and the hardware side, is rocketing, and it's making this a little bit more realistic. Yeah. So whether there's the ethical component as to which one is which. So whether we should or not, but there are aspects, like suturing in the context of closing up, the sort of thing that a first-year registrar is asked to do in and out because the experienced surgeons can't really be bothered, right? So that type of suturing could easily be offloaded or farmed out to a machine if there was a possibility for that to happen safely.
Yeah, but then what would happen to your experts? Would they ever become experts if your residents didn't get to do the menial task?
Yeah, absolutely. And I want to ask you about that too. But before, I have a question from Zieng, who says, "Hi, Ann, nice talk. How could the understanding of human response translate to surgical training outcome and efficiency? What is your thought or comment in that space?" That's a tricky one.
Yeah, my own student, my former student, giving me a tough question. I think yeah. So I think I think that's sort of a tough question. I think one of the reasons why we're sort of doing this work is that if you just look at, training outcomes like times, errors, things like that, it doesn't tell you what somebody did wrong in order to be able to, what somebody did wrong and what do they need to learn in order to be more like your expert. So I think the importance of understanding the human response, the physiological response or the kinematic response as they're learning these complex tasks, is it can start to give us some more information about what specifically went wrong, what specifically do we need to train, where should we sort of put our attention. We need to finish that paper, by the way. That sort of can inform, to take away some of the black boxness of a lot of these data-driven algorithms, but to really get at, okay, if we're actually going to try to teach someone how to do a task, let's use our data-driven methods to actually craft, a personalized and more effective training regimen for them. Hopefully that answers your question.
And so in this context, you, in your first study, you were discussing there are two specific tasks where VR actually impaired performance as opposed to improved performance. And I wasn't quite sure if I understood why you think that might be. So what do you
Yeah.
think was it about those particular tasks whereby having
Yeah.
tried them out on a VR made you actually worse?
Yeah, so the two tasks, I don't know if you guys can still see my slides, but it was the simple suture right here where they just had to pass the needle once and then do a knot tie, and the pattern cutting where they just cut the thing out. What was interesting to me was that we didn't really see any significant effects for this running suture, which is also a suturing task. So what's the common thing? It's suturing and it's tissue cutting. Those are sort of the two commonalities. And then for this running suture, why wasn't that so effective? They did the training in order. So tasks 1 through 9, essentially, like it wasn't that controlled because the residents kind of came in over the course of a couple months. But this was one of the later tasks. It also didn't require a knot tie at every single step. You just did suture, 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 and then tie the knot at the end. So I think maybe it's a little bit less of a complicated movement. So I don't know if that answers your question, but yeah, the
thing is left open, right?
Cutting and yeah, and both of these things, the ability to represent, and I should also say that the VR tasks, they didn't have great analogs for either of those. I mean, the energy one, it was kind of a cutting one. And then the suturing one didn't have the actual suture thread. We did look for our other study, this one, we actually did take their suturing task that included a suture. And so, but really the dynamics of that suture it just wasn't realistic. So I think you kind of break realism in some ways with these tasks, and maybe we just don't know enough about, okay, well, what are really the important key aspects of this task that we need to focus on, if there's specific kinds of movement or it's a specific kind of spatial, coordination that you can train with a lower fidelity VR based simulator, but at least it's one that's going to be driven in science. And I think that's my biggest issue with all of these VR simulators right now is, there's not much research that goes into them. They're sort of commercial products. But my concern is, are we really understanding the long-term impact of this on people's learning?
And I agree in the sense, I mean, even your last study, right? So you're saying, okay, what if we move the robots aside? Yeah. And my understanding is it is still quite difficult to figure out how the expert surgeon interacts with a complex task. But it's also true that our proprioceptive sensing is really quite garbage compared to, I don't know, our robots encoders and load cells. It's the ensemble of your sensing and your eyes and your proprioceptive sensing and your muscles, yeah, that somehow, I don't know, it's almost like black magic. So my worry about taking the approach that you're taking, where you're looking basically at tool space, Cartesian space, and joint space, which I think works very well if the mechanism is very accurate, as we build them in the lab. But if I now think how an expert surgeon's hand operates, I am not sure that, because it's what you were saying just earlier. It's what are they, if you abstract the skill set that you're trying to teach the surgeon to become the best surgeon, I think the jury is still out as to what exactly they are. But it's a very fascinating question, and one that I'm sure is going to tickle many of our audience for the rest of today, if nothing else. So if there are no more burning questions, I'd like to thank you, Anne, for a wonderful talk. Remind everyone that the talk is going to be available on the Hamlyn Symposium channel once we've had a chance to edit it. And so if you have colleagues who have missed it for one reason or the other, they can certainly get to the talk through the channel. And of course, this is a series of events throughout the months of June and July. So you're very welcome to go to the hamlynsymposium.org website, where you have a running timeline that tells you what happens next. And in fact, we've got Stephanie giving us a keynote tomorrow. So we've got an anomalous week where we've got 2 amazing keynote talks, one after the other. So with that, I'd like to thank Anne again for taking the time to be with us, thanking the audience for their questions and their time. And I wish you all a wonderful rest of the day. See you tomorrow. Take care.
Great. Thank you so much.
See you.